Thank you very much, Dr. Reamer. It's a pleasure to be here, and I want to add my gratitude to everyone who was involved in making this conference so successful. It's very impressive. We had a great day yesterday. Last night I was reflecting over the day and came to the realization that big focus on the importance of research. It shouldn't be surprising for a conference like this, but also on the importance of implementing that research, that knowledge, so turning knowledge into action. The inspirational remarks by so many of the participants, and really an uplifting, I thought, day in terms of when everything was put together. So one of the things we were asked to do was to describe ourselves, which is kind of awkward. You did a brilliant job, Dante, yesterday. I can't compete with that. So I'm vertically challenged, which usually isn't a problem. It's actually an asset when flying because you can fold up into smaller spaces. And my mother used to say that very special things come in small packages. I think she was thinking of the Tiffany blue box, but I took it anyway. And I just want to give you a little story that's related to my size. So I was at a conference and there was a podium like this, but when you stood behind the podium, you couldn't see the person. So it was just kind of from the head up. And it was very hot. It was in the center of British Columbia in the summer. It was about 90 degrees. There was no air conditioning. The room was packed. I had been there for a few hours. I went back to my hotel. I put on my shorts thinking, not a problem. No one will know because I'm standing behind the podium. I didn't check it out ahead of time, and they had the teleprompter on the floor, and I wasn't tall enough to read the slides, so I had to stand beside the podium in my shorts. It was very embarrassing. And another fun fact is that I have green eyes. And you may not know that only 2% of the world population have green eyes. So that makes us very unique. Except in the 16th and 17th hundreds, people with green eyes were believed to be witches and were burned at the stake. So we've moved along. I haven't experienced that yet, but you may have other reasons not to like me. As Jim mentioned, I'm from Canada, so hopefully you can understand my accent. We do say things differently, so I will say route and not route, and process. And then I know you're all waiting for it, so I will say it because it may not come up in the presentation. A. Okay, so I'm going to ask you for your indulgence. This is something that is fairly common in Canada, and I do it because I think it's important to have a small gesture that's trying to contribute to reconciliation with our Indigenous peoples. And so please forgive me if this isn't kind of the norm. So I am very privileged to be here on the ancestral home of the Creek and the Choctaw people, and I honor their elders and knowledge holders past, present, and future. And I live and work, the University of Ottawa is on the ancestral and unceded territory of the Algonquin Nation. And unceded means there was no treaty between the Crown, the King of England, and the Indigenous people. So the settlers just took the land without a treaty. So this is Ottawa, the Rideau Canal. And on the right, top right, that's Parliament Hill. And on the left. On the right, you can see the spires. That's actually the hotel, the Chateau Laurier, which is a Fairmont hotel. And what's kind of cool about that is it was to have opened in 1912. And the owner was coming back, and the little square box was actually the train station. And so there's a tunnel connecting the hotel to the train station. The owner was on the Titanic and died, and so they had to delay the opening of the Chateau Laurier. And what you see in the middle is the Rideau Canal. now. And so it's the longest outdoor skateway. It's 5 miles. Last year it was only open for a few days. The year before that it didn't open at all, the first time in history. And it's been open since the beginning of January. And so the other thing, it's a World Heritage Site. And it actually goes from Ottawa to Lake Ontario to Kingston, so about 100 miles. And it was built in the early 1800s, largely in response to, and thank you, to the US who decided to invade Canada at the time, the War of 1812. And it was to ship troops and supplies to the border to defend it against the US invasion. So that was 213 years ago. And I think the record is Canada and the US have the longest period of any two countries not being at war. And of course, we have a 4,000-mile undefended border at the moment. Okay. And the other thing that I wanted to say about this, so I looked it up. So today the temperature is 10 degrees Fahrenheit in Ottawa. And on the weekend, it's going down to -9 Fahrenheit. And we have already this year, we use Celsius, -40, and Fahrenheit -40. The two thermometers cross. And we've had several days of -40 in Ottawa. It's the coldest capital in the world. This is what we look like in summer. Go figure. And in June, July, and August, our average temperature is in the 80s, often around 85. So we go from very cold to very hot within 6 months. And have I done something? Okay. And then this is in the fall. So we have lots of leaves. And what I want you to look at on the far right of the screen, that's actually the University of Ottawa campus. So we're the largest bilingual campus, English-French university in the world. We have 50,000 students. So I teach in English, but all students have a right to write papers in either of the official languages. So what I'm going to talk to you today, of course, like so many projects, couldn't happen without a lot of help from a lot of people. So I want to acknowledge the funders and the team, and of course, most importantly, the participants in the process. And I have some disclosures, so I'm a medical sociologist. There's other pieces that are in my bio. I've developed frameworks and models in the implementation science space, not ivory tower exercises. It was working with groups who were trying to implement evidence, and we needed to figure out ways to make it more systematic and comprehensive. Not doing so good on the clicker here. I'm the co-editor of a journal, so the Joanna Briggs Institute Evidence Implementation. So if you have papers studying or describing implementation projects, this is a journal to consider, so that's my plug. And I've been involved in editing or authoring a number of publications that nobody seems to read because there's not very much in terms of royalties, except for the knowledge translation in healthcare. And all of the royalties went to fellowships for students. And I have no financial conflicts of interest, and I'm not sure that I want money from industry. That was a joke. And so I'm going to talk a little bit about knowledge practice gaps, and you heard about them yesterday, but I don't think they were defined or termed that way. Tell you about why we decided to make the planner, describe the process and the evaluation of it, and then quickly go through what the planner is like. The first slide is the cover of the planner. So the other thing is, this isn't actually a talk about implementation science, although it's all about implementation science. And implementation science is actually a field that's relatively new, the last 20 or 25 years. that focuses on trying to understand what are the factors that influence people choosing to make decisions based on research and other forms of knowing, and what interventions or strategies can we have to help facilitate the uptake of research into practice and into policy. So, what's an evidence practice gap? I really am not doing a good job on the buttons. Okay. This is a quote from Jeanette Ward, who's an Australian, and what's in brackets is what I've added to it, but the notion of we have lots of research in all sorts of areas, and that these new findings are really important and could improve the effectiveness and efficiency of healthcare and health outcomes. And as Dr. Reamer mentioned yesterday in his opening remarks, we can have all of the research in the world, but if nobody is actually making use of it, you're not going to see those benefits happen. And so we need to be thinking in terms of, unless health services, and I would argue community agencies and services, and healthcare professionals, as well as community service providers, need to adopt the evidence in their practice if we're actually going to get the return on investment that we hope is there from all of the research funding that we have. Okay, this is really funny because, okay, now that delays and anyway. So what are some of the statistics? So these data actually come from the US, you're included. It's not specific to the disability research. The Netherlands, Australia, the UK, and most recently Canada. So 30 to 40% of service users don't get treatments of proven effectiveness. So it's not about we need to do more research to find out what works. We know what works. No one's questioning what works. We're not getting it, right? The public can kind of understand that because there could be lots of reasons. So your healthcare providers aren't offering it to you. You don't want it. You can't afford it, right? So they can kind of get that. The second bullet, though, is really problematic. About a quarter of the time, all of us are getting things that we know do not, well, we may not know that they do not work. There is evidence that what we're getting does not work. And in some cases, it's actually harmful. So we need to be de-implementing that stuff, which would also free up resources to implement stuff that actually works at the same time. So the context for the planner is stroke, and you probably know this. 1 in 6 people worldwide experience stroke in their lifetime. It's about 15 million people every year. And in Canada, the incidence of stroke is 1 in every 10 minutes. In the US, it's 1 in every 40 seconds. So since I've started talking, many people have had strokes, and 1 in 4 people die from a stroke every 4 minutes. So horrendous. About a third of stroke survivors have physical challenges that make it difficult to take part in daily activities and interactions. And over the past 20 years, healthcare, the use of evidence-based guidelines, for example, has resulted in fewer people dying from stroke, which means that more people are living with longer-term disabilities. So that's the context. What do we know? What's the evidence? What should be implemented? And this was referred to several times yesterday by different speakers. Exercise, the importance of it. So we've got good randomized control trial evidence in the area of stroke. It improves mobility and quality of life, improves strength, balance, and cardiovascular fitness. It improves or maintains mental function. It helps to manage blood pressure and prevent future stroke, right? So we've got a really good intervention here. But most stroke survivors don't have access to exercise programs in their communities. So, the evidence practice gap. Despite all of the benefits of exercise and evidence-based recommendations specifically about what type of exercise, how should it be delivered in the community, most people still don't have access to such community-based exercise programs. And I know many of the the talks yesterday were around telehealth and how that can improve getting access to things as well. So the Canadian Partnership for Stroke Recovery is part of the Heart and Stroke Foundation, which is the advocate for heart and stroke conditions and a funder as well. They have a knowledge translation advisory committee, and we use the term knowledge translation in Canada or knowledge mobilization, but the process of how do we get research into action. And the committee, which includes people with stroke and caregiver partners and stroke recovery experts and healthcare providers and policymakers and knowledge translation people like me, got together to say, what can we do? There was a funding opportunity, and could we come up with a project that could demonstrate how can we accelerate the uptake? And the healthcare providers identified depression. And between a third to half of people with stroke, when they're having the stroke and then afterwards, have mental health issues and often suffer from depression. And so this is clearly an important need. And it was the people with stroke who actually argued against it and said exercise should be a higher priority. And if we get exercise, that will also help our mental health. And so they convinced the healthcare providers to focus on exercise. And so the other thing that in the discussion, what the people with the lived experience of stroke were saying, and we have evidence of this, so fitness organizations in the community are sometimes reluctant to have people with stroke because they don't know how to manage them, they're concerned about safety, and so it's really often not a welcoming environment for them. People with stroke also say they feel uncomfortable being in that kind of a setting with the disabilities that they have, and so they don't really want to go to those kinds of facilities. So the notion of, well, maybe having an exercise program that's specifically designed for people with stroke might be a good fit. And we actually were very lucky because there we go. Maybe not. We have physical therapists in Canada who've actually developed evidence-based programs for stroke exercise in the community. The programs are slightly different, all based on randomized controlled trial evidence. So we had the intervention. That was great. And this quote came from some of the qualitative research that we did. And so it's a program manager who said, I've been involved in various program planning groups, and there's been no map. Everybody just kind of gets together, starts throwing out idea, and there's no real structure for how to move forward. And I think that's why a lot of the times everybody has the right intention, but the program doesn't develop in a way that's sustainable. And so illustrating this is the problem in the community for all sorts of reasons. So our goal was to come up with an evidence-based planner to help community organizations actually implement exercise programs for people with stroke in the community. And okay, I've lost the page. We'll wing it. So what is this thing? It's a resource for implementation planning. It was developed with key stakeholders. So the motto of nothing about us without us was critical to our approach. In Canada, we would say, we call that an integrated knowledge translation process. So if you're wanting to create things that will be used, you need to get the people who would use them to be part of the development process. And we wanted it to be based on implementation science frameworks and evidence. So 6 guiding principles, and I think these resonate with many of the presentations yesterday. So we wanted the exercise program situated with the community and provided by organizations with a mandate for community services. We wanted the principle of participant-centered, so putting people with stroke and caregivers or caregiver partners at the center of the decisions, seeing them as experts working with service providers to achieve the best outcomes, using a participatory and inclusive approach, so people with stroke and relevant stakeholders, including healthcare partners, involved in co-creating the implementation plan. Evidence-informed, so uses effective approaches to planning and implementation that incorporates the use of local data and decision-making. Aimed at strengthening participant health outcomes, so why are we doing this? We actually want people with stroke to have better health outcomes. And we want the programs to be sustainable. So we also did other research that shows that many communities set up these programs, get funding from a charitable group. When the money runs out, they shut down the program. So really, in the long run, isn't helpful. So I work a lot with different kinds of groups, and this is the only slide. And I'm well aware that there may be people in the audience that may experience or suffer from TAS and FAS. So I actually use an approach, a trauma-informed approach. And so I want you to pay attention to the people at your table. And these are some of the signs and symptoms to watch for. So they start shifting in their chair. They sigh. They roll their eyes. When it really gets bad, they start to mutter things like, when's this going to end? If they're really getting worse, they'll say things like, just kill me now. So TAS is theory-averse syndrome, and FAS is framework-averse syndrome. And the research that I've done demonstrates that men and physicians suffer from it more. And so think about the context. So it's people who do not like frameworks, and they like to just get on with things. And so, you know, a DIY job where you knock down a weight-bearing wall because you didn't think that maybe it was actually holding up the roof. So the importance of theories and frameworks is to give you that guidance. And I'm not going to bore you with the details of what they are. We use the Knowledge to Action framework, which is actually a meta framework based on 30 planned action models that identifies the key elements that you probably should be thinking about if you're trying to engineer a change. And the other one was Implementation Roadmap, which breaks that down into more manageable bits. So that's all I'm going to say about theory and frameworks, and hopefully I haven't traumatized you too much. It was a multi-step process. We started out just by gathering information. We talked to 18 community stakeholders, did interviews with them around, you know, how do they make decisions about exercise programs they want to implement? How do they approach it? I'm pausing because it comes and goes. We looked at the literature. We developed a draft. We shared it with the team. We shared it with some clinicians and implementation science experts. We had 8 community stakeholders, including people with lived experience with stroke. We weren't asking them to comment because they wouldn't be implementing the programs, but we wanted to make sure how we talked about people with stroke was appropriate and respectful. And so we had them go through looking at it. And we have a section on the importance of engaging people with stroke and suggestions for teams for how to do that. And we wanted to make sure that we got that part right. And then we did more development, and then we sent it out to 13 health partners and administrators and program managers and fitness professionals across the country to get their feedback. and revised it again. And then we sent it out to 39 people in the program planning field to actually assess what they thought about it. And then we had a review process, and then we finalized it. And the evaluation, there were two. So the one with the community program planners was to really find out, did they think this document would be useful? Would it be acceptable to them? And what did we need to change to address those issues? And then we did a field test. So we actually had 5 groups from across the country volunteer to use it. And we were interested in seeing how it worked in the real world. And we wanted to find out from them whether they thought, or what they thought might have been the benefits of using the process. And that was really important because they actually told us really cool things about how they were using it, which we then incorporated into the planner as tips, real world tips. So this figure was just to show that we had these 2 pieces, the user evaluation and the field test. And with the user evaluation, we had all of the people who were field testing it, so they were giving us the same kind of feedback. But then we also got people who had past experience implementing programs in the community, so they kind of knew how to do it, and we knew that some of the things we were suggesting weren't things that are typically done in the community, so we needed to find that out. And then we got people who had never implemented, so they were the naive group. And that was a very valuable exercise because they didn't know what they didn't know. And so they would look at it and say, oh, we wouldn't do that step. That seems like really complicated. And what we found out was we had failed before each step to say, this step is important because. And so they were just looking at the step and deciding it wasn't important, not understanding why you would do it. So we changed the structure so that each section actually starts with a box that says, this step is important for this reason. So this is an infographic. Don't try to read it. That's not why I put it up here. But it was just, it was the journal for a couple of $100 would create these infographics, which really are nicely, if you go to the journal article, it's attached to the paper, which summarizes the findings, which I will do now. So of the 39 people, all of them were very positive. They thought it was comprehensive, included useful tools and templates, included valuable real-world examples for planning teams, areas for improvement, making it more clear, and the need for the steps, refining navigation, creating more action-oriented content. And then most participants commented that their knowledge and confidence increased after reading the planner, and the use of the resources would improve their approach. So part of the questions were, do you think doing this would be better than how you do it now? And often that was the case. In terms of, there we go, the field testing. So I mentioned it, longitudinal design. So we track teams over time, very much like the NICIP approach that you heard about yesterday. We had 5 program managers and coordinators, 5 rehabilitation professionals, and 2 fitness professionals. And so they used the planner, and depending on the context, they used them for 4 to 14 months. COVID happened in that period, which screwed everything up because they had to shut down things. And then every 6 weeks, we'd have check-in points with them, which were interviews, but we didn't call them interviews. We just called them check-ins, where we'd ask them, you know, what step are you on now? How are things going? With the past step, what were the challenges that you had? How did you solve them? Those kinds of things, so that we could build all of that into the guide. And so this is from the paper presenting the findings of the field test. And so in general, all of the teams said it improved their implementation planning knowledge. They had more positive attitudes towards implementation planning, engagement in new implementation planning activities, so they were actually doing things. So we had one group in their traditional way of doing it. They had a manager, and the manager had total responsibility, and they would decide which programs to implement, and that's what they did. And so the notion of you need to bring people together and decide how you're going to do this was completely foreign to them. and they gave it a try, and it actually worked out quite well for them. And I mentioned we then took the tips from these teams and put them into the document. So, one more, come on. There we go. So what were the factors that these teams said supported their being able to use the planner? Well, you're not going to be surprised. The organization having a strong belief in the role of community-based organizations providing health, improving the health of people with stroke, valuing evidence-informed planning approaches, staff with dedicated time and resources for planning, and team leaders who are open to trying out new approaches and activities. And they told us some of the barriers or challenges was organizations focus on quantity over quality, so counting the number of people taking the exercise as opposed to actually thinking of the bigger picture. The one-person show model, which kind of goes against the whole philosophy of engaging everyone in meaningful ways. And you can think of the African proverb, if you want to go fast, go alone. If you want to go far, go together. Organizational restructuring and changing priorities, messing up everything, and of course, COVID. And so this quote is from one of the program coordinators. So at first, I'll be very honest, it was very intimidating. I'm like, oh my gosh, this is the most information. It was a little bit overwhelming, and I think the person meant it was very overwhelming. But once you get over the size of it, I can't stress enough how great a resource tool it is. And so this is a challenge, I think, with any kinds of educational things. You want to present it in as much detail as people need, but it scares them when they start to look at it. But if you can actually get them to the point where they read through it and they can see that it's in manageable chunks, they go, oh, this is really helpful. But that initial response of, oh my goodness, it's 50 pages, you can't expect us to do this, is a common one that we heard. So the implementation roadmap, and this goes back to our book on knowledge translation in nursing and healthcare, which lays out, and we use the analogy of a journey, and so don't worry about this. I just wanted to show you kind of 3 phases, 8 steps, a whole bunch of activities under those steps. And we use the notion of a journey as things happen over time. And you probably have a map to get you where you need to go. And sometimes there's construction and detours and roadblocks, and you have to deal with those as you go along, and it's not a linear process. And groups said, but we want to do this quickly, and this sounds like it's going to take forever. And we actually have evidence that taking your time to get the planning right saves you time in the implementation. But people like to jump right to the implementation. So, very quickly, so these are the 3 phases. Phase 1, so understanding our needs, population, and resources. And so we deliberately wrote it this way, so it's not what are your needs, concerns, whatever. We want the people reading it to be thinking of it from their perspective. What do we want? What's our approach? And so there's 3 phases here. The call to action, which is very much the coalition building, conducting a community scan, and then selecting the program and initiating the planning process. And then the guide breaks down each of these steps, and as you can see, this is, form the planning team, involve the community, identify the key partners, figure out the champions, the roles or responsibilities. How are you going to make decisions together? You'd think that would be kind of a common thing, but, and maybe it doesn't apply in the US. But what we found with our participants was they never stopped to actually have a discussion of, are we going to vote on things? Are we just going to have a discussion and kind of agree? Are we going to, 3/4 of us have to agree, and then if somebody dissents, does that mean it stops everything? In my school until 5 years ago, all decisions were consensus-based, and the definition of consensus was one professor objected, the recommendation was declined. So it's very hard to change things if you just have one person say, I don't like that, and that's how you define consensus. So having that discussion, and so in the planner, it actually talks about have a discussion of how you want to make decisions. Understand the evidence supporting exercises. So we had the 3 programs that were out there. Thank you. But you can use any program, right? Or evidence for it. But it's how do you build the group's capacity to actually make decisions about what program's going to work for us, what's the best thing. And maybe they pick pieces from different programs. Gather community information. So this is the scan. What's the level of participant interest? We found out there were groups that were putting on community programs that never found out if there was a demand for it. And in another project, when we interviewed groups about why their programs failed, it was nobody showed up. It's like, well, was that a surprise? And they said, well, it was, because we had no idea that nobody would come, but they didn't actually canvass anybody to find out if people wanted the program or not. Assess the program fit with the community. So we use the FAE, so feasibility, application, acceptability, equity, and affordability. So once you've decided what it is you're going to implement, what's your filter for making the decision that it actually is going to be a good fit for you? So you may pick a program that's too expensive for you to actually implement. So you shouldn't be implementing it if you can't afford it. And it may be intuitive that groups would think these things through, but for all sorts of reasons, it may not happen. Achieve agreement to proceed with planning or not, and so a big part of it was it's okay to decide the time isn't right to actually implement this. Don't proceed if it's not going to work. If you're proceeding, firm up the business case. We found many organizations, this wasn't a typical step. They would get funding from an organization, and then they would spend the funding, and that would be the end of it. And they didn't think that maybe they should be figuring out sustainability and have a plan for when the money runs out, how are we going to keep doing this? Is it going to be fees from participants? Is it going to be, and so in one jurisdiction, the health system actually pays the fees. So it's considered a program of the hospital post-recovery. So you go into rehab, and then when you're discharged home, you get access to the program. If proceeding, begin developing the implementation work plan. So actually now you have to figure out how are you going to implement it. And so there's gazillions, too many tables and templates and worksheets for all of these steps. And we don't encourage people to use all of them. It's like we put in, we didn't have it, the business case one. People said, well, we don't know how to do a business case. So we found a template and put it in for them. So all of the text comes with tools to help support doing the action. So phase 2, building the solutions that work for us. Identify the barriers to the program, develop solutions, and then plan for the evaluation. And I'll just skip through these to get to the last step. Oh, actually putting in a step, which you need to be thinking of from the very beginning. How are you going to sustain your program? And so it could be things like your fitness instructors will come and go. So what's your plan for maintaining a group of fitness instructors who can take over the program and have the training to be able to do that? And the last phase is implementing, monitoring, and maintaining the program. So here, implement the program. So prepare to launch. So you need to create a checklist. Are you ready to launch? If you're not, address those things. Deliver the program and celebrate. Really good evidence. You want to support people implementing? Celebrate the successes. There's lots of challenges to get things implemented. People like to be praised in terms of, great job, you've got to step 7. And all of these things, the benefits, facilitates evidence-informed decision-making, meets the community needs, increases the sense of community ownership, improves stakeholder buy-in, strengthens teams, builds skills amongst those involved, and improves satisfaction of the planners and the participants. And I'll leave the last comment to a person with stroke who is in one of these programs. My balance and coordination has really improved, and it should do, because these programs are based on randomized controlled trial evidence showing those are the outcomes when you do these programs. And I've met other people in the same situation as me, and I don't feel like I'm going through this alone. The March of Dimes, which is an organization that provides services to people with disabilities of all ages, we turned the planner over to them. You can get it free of charge on their website. Encourage anyone, it's not copywritten. We want people to use it. If you have different contexts and you want to use this as the basis and modify it for your own purposes, go right ahead and do that. We'd be happy for you to do that. And I'll leave you with this quote, apparently from Leonardo da Vinci. I've been impressed with the urgency of doing. Knowing is not enough, we must apply. Being willing is not enough, we must do. And I think yesterday's presentations really highlighted the emphasis on and what many of you who are here are doing, and you're doing it, and that's the way we're actually going to bring about change that's going to improve people's health and welfare. Thank you.